Hi everybody, Dr. Bob Coleman. I am one of the emergency room physicians here at Forum and UES up here in the Cleveland area. This is the beginning of what we hope to be a pretty decent demonstration of clinical scenarios, and hopefully this will expand in the future for our blog and for CME. Today, what I would like to go over is just a couple of scenarios, one in particular, of a pretty good case that came in to the emergency department several months ago. This will be hopefully about in 10-minute intervals, and then we'll have hopefully a total of 20 minutes or so on the case. And after that, hopefully a couple of guys will be able to respond back with questions, maybe some thoughts as well with regard to this case. The outline today is an abdominal pain case, and it's actually just a case study that we're going to go over. And here we go. How we would like to do is start out with an EMS run. A dispatch called to the residence at a time out of about 8 o'clock in the morning. On scene of a 38-year-old male with abdominal pain, consists of sharp stabbing discomfort, rating about 10 out of 10, rating bilaterally to both shoulder blades. Began about 2 hours prior to EMS arrival, and the prior night he was out celebrating with his buddies and just got in at about 3 o'clock. On EMS assessment, it actually concurred with the dispatch. No chest pain. It concerned some shortness of breath. It was kind of hard for him to catch his breath. He confirmed some nausea with associated vomiting, all prior to the EMS arrival, and no loss of consciousness or associated trauma on initial workup by EMS on arrival. Vital signs, 86 over 50, heart rate is regular, about 140 beats per minute, respirations are 30, saturations were okay on room air, blood sugar registered at high. One of the things here with regard to vital signs, it makes no difference what level of training you're in, whether you're an EMT intermediate, EMT medic, physician's assistant, nurse assistant, physician, it doesn't really matter. Vital signs are vital signs, and one of the things that you really have to pay close attention to is underlying tachycardia. Tachycardia is actually one of the most sensitive vital signs in patients who are sick, as we all well know. Respiratory rate, patients being a little tachypneic, is very sensitive in certain infections and sepsis as well. So when you look at your vital signs, please don't just pay attention to your blood pressure, because sometimes patients can decompensate quickly where the blood pressure will go last. One of the things you look at here is a heart rate of 140 with a high blood sugar with a patient with abdominal pain. Already you should be formulating a differential diagnosis prior to you even entering the patient's room based on the EMS report. Here's the EKG that was actually sent. It was actually a sinus tachycardic rhythm. The patient's EKG here showing the rate's a little bit slower than it was upon arrival. But right here we see a sinus tachycardia with a little left atrial enlargement, kind of non-specific findings for a man this age. On arrival to the emergency department, the RN and MD concurred with the EMS examination. Keep your ears open when EMS actually reports things like this to you. It's a good idea to actually formulate a real strong course of what you're going to do just based on an EMS run. Physician's assistants out there, you guys can resuscitate patients very, very well. A lot of you that work for us are medics, but this is a case in which you should be walking into the room with the physician, and the ER doc should be close behind if you do pick up this chart. So do listen to the EMS report. This is very, very important that you do this, because the paramedic sensitivities of picking up things in the field are quite high, and we'll discuss that at a later time. The case study here, the patient was miserable. He's pretty much what he's saying in quotations. He's miserable. He was answering questions appropriately. He was normal cephalic. His pupils were okay. He smelled faintly of an alcoholic beverage. Remember, alcoholic beverages are the ones that give you the aroma of alcohol. Alcohol in and of itself usually doesn't have an aroma, but alcoholic beverages, as to whatever you mix this beverage with, or the alcohol with, will give you that aroma. Jugular veins were okay. Neck was normal. His lungs were clear with good excursion. He was tachycardic. His abdomen was tense upon arrival, but not so rigid, just a little tense. He was guarding the epigastrium. Take note here, he had a slight discoloration over the flank area. This is something that you need to kind of, for this particular case, pay close attention to. There is a specific term for this that I'm not going to give up during this lecture. That's something you'd have to dig for. I'm sure most of the guys know what that is. There's no pulsatile expandable masses that were palpated or auscultated. Bowel sounds a little hypoactive. Femoral pulses, tachycardic but present. There was no significant delays or discrepancies. His neurologic examination, he had crescendoing anxiety levels based primarily on his pain. 2 large IVs were started from EMS, which is always nice when those guys do that. I've always lectured to the EMS guys. It's more the large, it's the bore of the IV, not the length of the IV with regard to fluid resuscitation. So if these guys can get 18s or bigger in these patients, that's wonderful. He had 2 liters of nasal cannula oxygen, monitored bed, and blood work was drawn and sent to the lab. On his complete blood count, he had a white count of 24,000. His hemoglobin was 10.8 with a crit of 26. Platelet count was okay. His labs here showed a sodium of 124, potassium of 3, chloride 96. His bicarb was 80, only 18, BUN and creatinine of 30 and 2.1. His glucose of 834 with an amylase and lipase of 460 and 2650 respectively. The calcium is 7.2, magnesium 0.6, one of the most common electrolyte disturbances off the streets in patients who are alcohol enthusiasts, if you would, or had a nice little binging episode, is hypomagnesemia, something to pay very, very close attention to. Lactate of 3.2 with an albumin of only 3. His venous blood gas analysis showed a pH of 7.2. We are starting to do the venous blood gas analyses now in the emergency department, becoming very popular. You can actually spare your patient of having an arterial stick. Venous blood pH versus arterial blood pH is the same. PCO2 and PO2, of course, we know this is not rocket science, will be a little bit different, but the pH itself is what I wanted to know. I wanted to know if this guy was acidemic and or acidotic. He clearly is acidemic, noted here on his pH. This is actually his venous blood gas analysis. Later on in the case, I did do arterial blood gas, but for reasons I'll explain it a little later on. Urinalysis showed 4+ glucose plus ketones. He had a tox screen positive for tetrahydrocannabis or THC. Marijuana, for those of you who don't know what that is, of course we all know what that is, working in the emergency departments. His chest x-ray was nothing acute, rectal examination was negative. Chest x-ray with acute abdominal series overall was normal. Bedside ultrasound, this is actually down, a lot of our ER docs use bedside ultrasound or fast examinations. Dr. White is a very strong proponent of ultrasound. Hopefully at a later time we'll have Dr. White maybe give a separate lecture on ultrasound, what he's able to find with bedside ultrasound in patients with abdominal pain. Dr. White uses ultrasound religiously, almost every shift, and really swears by it that he really likes ultrasound for patient bedside examination. I know several doctors who like using it as well, but that would be for a later time. Here's a CT of the abdomen and pelvis that was obtained on this young man. He had a problem. We had a big issue here. If you take notice to the outline, here's the pancreas here, kidneys are coming into play, the cruce of the diaphragm, liver, stomach is up here. This was a non-contrast CT of the abdomen and pelvis. This is normality here. This is abnormality here to the right. And if you take notice that the geographic, or might I say anatomic outline of the pancreas is completely obliterated. I mean, it's completely obliterated. I mean, you cannot see it obliterated practically the entire body, tail, and the head of the pancreas here. This is all hemorrhage, which is consistent with the patient having a hemorrhagic pancreatitis. So what is your best guess diagnosis? You should have a best guess diagnosis or at least a differential diagnosis. Once you leave the patient's room, you should know what you're going to be doing, what you think the situation is, based on a history gathering from both medics, history gathering with yourself, physical examination, head to toe, and formulating differential diagnoses as you are working through the patient. Lab work is nothing more than it's supportive of your suspicion, but your differential diagnosis should be pretty quick in a patient like this.